Okay, so today my talk is on how to design your surgical study effectively. And I'm going to talk actually mainly based on my experiences and what I see happen very, very commonly in all the thesis evaluations and the thesis progress evaluations that I have come across during general surgery and pediatric surgery. Yeah? So it'll be a very practical one, basically how you deal with your own study. Right? So back to the basics. What is a manuscript, right? Because eventually, if you work backwards, what you have in your manuscript should reflect what you did in your study, right? And hopefully everyone's research study will end up in the publication of a manuscript. So I find that this is a very common misapprehension, and there's a misunderstanding on which parts of the manuscript should include what information. So the introduction section is basically why you did it, what made you interested in the topic, what gaps in literature are you trying to fill when you write an introduction. Next is the methods. Next is the method section, and the method section is basically what you did in your study. That means just describing the activity of what you did. So whether it's how you collected the data, what kind of data you collected, what tool did you use, who you asked, how you approached the patients, where you found your patients, where you found your case notes, your logbooks, where did you retrieve your data, right? So it's very, very factual. It is describing what you did. The results is what you found after you did the study, which means then it's about the data that you collected, demographic data, the measurements, the outcomes, complication rates, whatever, yeah? So often people mix up results and methods. So they'll put a bit of results in the methods and they put a bit of methods in the results. And then often, most commonly is actually the discussion section, is what you think about your results. And often the mistake is that you put an opinion about your results in your results. So you say something like, oh, interestingly, I found that the rate of complications was higher in laparoscopic cholecystectomy, and this may be because, but all this hypothesis should be in the discussion section, not in the results, okay? So what we'll focus on today actually is the methods, because that is about study design, yeah? So what are the characteristics that should be included in your research design? Number one, there should be neutrality. And what is neutrality? It is being free from bias. That means you design a study to make it as free from bias as possible. And this bias may be unseen or obvious, okay? Reliability. Reliability is that when someone else tries to repeat exactly the same study, they will get the same results, similar results, okay? That means if they use exactly what is described in your methods section, they will be able to produce similar results. What's validity? Validity is that the tool that is used is the correct tool, yeah? And finally, generalizability means that your study and your results can be applied to a larger population. Now, I put this in red because this is not always possible, especially in rare diseases, or if there's something, for example, rare mutations, rare presentations, then you may not be able to generalize your results. But by and large, in most studies, there should be some kind of generalizability to a larger population, okay? So 5 Ws and 1 H. You have to identify who, so identifying the subject or participants of your research, identify what, which is the main focus or the topic of investigation, when, which is determining the time frame or the period relevant to your research, where, which is the location or context of your study, why, which is understanding the purpose and significance of your research, and how, explore the methods and approaches to address your question, okay? So again, actually, the crux of today's discussion is really how. How do you design your study so that when you present it at your thesis progress evaluation or when you write it up and you send it in for a manuscript, people can't pick lots of holes in your design, yeah? So it's really all about the methodology. I believe you've had sessions on research questions, objective and hypothesis. So today, what we're talking about is data collection, measurement, and data analysis, right? And this is usually really the core components of methodology. So data collection, these are what I've noticed are very, very, very common pitfalls, right? Some of you may know that I sit in on your general surgery thesis evaluations as well. And obviously I do thesis evaluations for our pediatric surgery program. Yeah. So these are the things that I see very often repeated. Okay. So first of all, wrong method technique. For example, you have a study where you want to look at knowledge, attitudes, and perceptions of geriatric healthcare services available in the Klang Valley area. Okay. And your target population is Malaysians over the age of 70 years. And your technique is Google Forms. So what do you think is wrong with this? What's wrong with this technique?
Internet.
Exactly. They don't know how to use Google Forms. Maybe they don't have internet, maybe they do, but it's on their smartphone and they can't see because they don't have the right glasses, or right? So straight away, you know, you're not going to get the information that you want, right? Data not raw enough, also very common. So if you're looking at, let's say, socio-demographic factors affecting survival rates for breast cancer amongst women in Selangor. And then when you collect your data, you put your age brackets as such: less than 21 years, 21 to 40, 40 to 60, more than 60. You have already categorized your ages so early that if, let's say, the difference was at, say, 34, you find a difference at 34 years old, how you collect your data would not be able to allow you to detect that difference, right? So if, let's say, it happened to be that in reality, there's a difference in survival in someone diagnosed at 41 years old versus 44 years old. Again, because you have categorized your age this way, you would not be able to get that in your study, right? So don't collect your data, don't categorize your data too early. Get your data as raw as possible at the time of collection. Okay, moving goalposts. Okay, so this is also very common. Incidents. So let's say if your study is on the incidence of post-procedure complications after percutaneous endoscopic gastrostomy. Okay, and your inclusion criteria is every patient who had a PG in UMMC from 2019 to 2024. Okay, you got 5 years. And then suddenly, as you're looking through your notes, you find that, someone with a PEG has a cologastric fistula. But none of the other patients that you have looked at so far in all those years, 2019 and 2024, have this complication. But this complication occurred in a patient who had their PEG in 2018. And then you're like, yeah, I really want to include this rare complication. So then you extend your data collection, but you cannot. Okay, you cannot, because you have to stick to the inclusion and the exclusion criteria that you determine for your methodology. Otherwise, there will always be something that makes you change your goalposts, move your goalposts, and then you have to redo a lot of the work. Okay, so once you have determined your criteria, once that criteria has been approved, stick to that criteria. Unrealistic expectations, not enough time, not enough help. Okay, this is so common, right? So let's say you want to do a nationwide multi-center study on mid to long-term outcomes of bariatric surgery. Okay, so then you have to think, what does mid-term mean? What does long-term mean? If you want to do something that's nationwide and multi-center, how long is it going to take? How many people out there are you going to need to help you collect your data in a complete way, right? And if you think about all these things and you come to the realization that, okay, that is probably not a very practical thing to do, then well done, because then your expectations have become realistic and not unrealistic. Yeah, but this is very, very common. And then also we forget the confounders, okay? Because many of you don't have a lot of experience doing research, yeah? Don't have a lot of experience collecting data for a large population. Some of you may have case series or case reports, but most of you, I will dare to say, don't have a lot of experience, right? So you forget there are confounders. So for example, a prospective study comparing the impact of an e-learning module on screening for colorectal cancer pre and post implementation on referrals for colonoscopy. Okay, so this is a prospective study. You want to know the impact of an e-learning module on screening for colorectal cancer, pre and post implementation, yeah, on referrals for colonoscopy. And your target participants are medical officers in outpatient primary care clinic. So let's say you include RUCA, PPUM. Okay, so our primary care. Can anyone tell me how would that be a confounder? Any volunteers? Okay, well, yeah.
They could have done attachment with us.
Okay, so Ida, yes, come, tell me. Those who have done an attachment with us, but more than that, let's say they haven't done an attachment with us.
But they could have some teaching from us, CME Breakfast Club. I don't know, probably.
Yeah, exactly, right? So someone from RUCA PPUM versus Klinik Kesihatan, I don't know, Sabak Bernam or whatever, right? The exposure, right? The exposure to specialist level surgeons who do colonoscopy and screen for colorectal cancer is very different. So you can skew your results that way if you don't remember those confounders. Okay, excuse me for 2 seconds while I close that door that's alarming, and I'll be back. Okay, good. So yeah, so remember, you have to think about all these confounders when you organize your data collection. Yeah. Okay, so next, measurement. Yeah, you might measure the wrong thing, you might measure it wrongly, and you might use the wrong tool to measure. Also, all very common pitfalls that I see. Okay, so what does this mean? Measuring the wrong thing. So examining, let's say this is your study, yeah? Examining the effectiveness of a new educational program designed to improve students' critical thinking skills. And what you're going to measure, you're going to look at students' performance in a multiple choice test. Okay, so I think Ida has answered. I think someone has answered. Anyone else wants to try? What do you think we're measuring? What's wrong here? Anyone?
You can't test critical thinking with multiple choice.
Okay, no, thanks Yue, but you can't answer this question because I want the trainees to answer this question. You will know all the answers. Did any of you catch what Mr. Tan was saying?
Yeah, because if it's a MCQ, the answers are there. You just need to pick one. Whereas if you want to test for critical thinking skills, maybe like in a Viva or in an essay, something that an answer needs to be expanded, I feel.
Yeah. Okay. Very good. Yeah. Okay. So you're all getting the hang of it. Yeah. So you have to look at the research question that you want to answer in your study, the objective, and then you have to see, are you measuring that objective are you measuring that outcome in the correct way to get what you want? Okay, very good. So measuring wrongly. Yeah. So for example, determining the rate of complications post-lap cholecystectomy performed by specialists versus those performed by surgical trainees. Okay, so that's your study. You want to look at complications post-lap chole, specialist versus trainee. Okay, and the outcome you choose to measure, number of emergency department visits made by the patient in the first post-operative week. Okay, anyone? Give a try.
They could have SSI, but they did not go to emergency department. They can go to Klinik Kesihatan instead.
Very good. Yeah. Okay. So exactly right. So if you use this measure, it is not an accurate measure because exactly they may not come to the emergency department. They may go somewhere else, or they may stay at home, or our patients sometimes very blurred. They don't even come when they're unwell, right? So you'll be missing all those that don't turn up to the ED or actually come straight to our clinic. So next, using the wrong tool to measure. Determining the rate of burnout amongst surgical trainees compared to specialists according to years of experience in the field. Yeah, determining the rate of burnout amongst surgical trainees compared to specialists according to years of experience in the field, and you use the Maslach burnout inventory. Okay, so you need to Google a little bit to find out, yeah, what this is. But can anyone tell me why might this be an example of a wrong tool to measure? So it's a good study, right? It's an important study, knowing the rate of burnout. Why is this considered the wrong tool?
I'm not sure, Prof. If this
Not
is
sure.
the correct, if this is the correct tool to use for all of us. Never heard of it.
Okay, all right. So basically, there are actually burnout questionnaires specifically for physicians. Okay, and if you use this was actually, if you read about this burnout inventory, it was actually created for research, not for implementation on the ground. Yeah. So there are also other burnout questionnaires for workers in general, for employees in general. But there are now actually specific questionnaires for physicians. So if you want to do a study like this, which is very important, you actually want to choose something that's more specific for physicians. And I'm not sure that there's one even available for surgeons specifically, but if there is one, then that would be the better one to use. Yeah. So those of you who have sat in on many of our evaluations, you will know that this is the pattern that we see, and this is often the feedback that we give you. Yeah. All right, so data analysis is the next thing. And what are the common pitfalls? So I call this your imaginary friend, the statistician, because very often you belum jumpa statistician lagi, but you can present some statistics that you don't quite understand. Yeah. So the statistician should not remain an imaginary friend. It should be a real person that you have consulted before you present your thesis proposal and evaluation. Okay, and why is that? Because again, one of the most common reasons that you cannot finish your study is that because there's an inadequate power calculation and sample size estimation, it makes it an unfeasible study. Okay, that means too big a sample size, there's no way you can collect all your data in time before you're supposed to pass up your thesis. All right. And final one is that you cannot explain the analysis. This is super common, right? We ask you, why do you choose that number? Why do you choose the effect size? Why do you choose that power calculation? And then you can't explain. You say you talk to the statistician, but you can't explain what the statistician tell you because you didn't understand it. Yeah, so that's also pretty common. While we do not expect you to have the level of understanding of a stats person, a stats expert, we do expect at least that you understand what is the reason that your study, okay, has that particular analysis applied, right? Okay, then finally Gantt chart is your schedule. Everything takes longer than you think. Okay, so ethical approval somehow always takes longer. I don't know why. Data collection always takes longer. So those who have allocated 3 months, it usually ends up being 6 to 9 months. Those who have allocated a year, it usually ends up being 2 years. Yeah. Data analysis also takes time because first of all, you have to collate your data, you have to organize your data in a way that is approachable for the statistician, and then you have to find the time in the schedule of your very busy statistician, whom everyone is chasing last minute, not just clinical masters surgery, but clinical masters in the whole faculty. Everyone is chasing those few people to help them with their stats. Yeah? So remember that everything takes longer than you think. So work backwards. Give yourself double the time that you think in your head, even triple the time to allow you the time to be able to finish your study in time. So if you have to pass it up, say for peds surgery, it is 6 months before your final exam. Work backwards and give yourself ample time with buffer to be able to complete your schedule. Yeah. Okay, so this is, I'm going to ask for you to read this project, okay, this project description, and tell me how, if you are in my position, all right, so pretend that you are sitting with me in the thesis progress evaluation, you are reading this summary of a project. What are the questions you would ask to improve the methodology of this study? Or what are the flaws you might point out? I'll give you 30 seconds to read it, think about it, and tell me what the flaws are. Anyone?
So the flaws would be district hospital in Sarawak because
Yeah. Why is that a flaw?
so because it is high tech, isn't it? It's reconstructive surgery, so it should be in secondary hospital or tertiary hospital usually rather than the district.
Yeah.
follow-up.
Okay. Good. Yeah. All right. Good. So that's one. What? Anything else?
How do you do emotional survey?
Ah, very good. Okay. Good. Any issues you might encounter? I'm giving a few clues here. When you talk to patients, any issues you think you might encounter?
Depression, so might need a refer to psychiatrist.
Uh, okay, maybe, but a more basic issue? Language, right? Language might be an issue because you're looking at something that can be quite subtle, right? Satisfaction with body image, psychological distress. Yeah, it's not something that is binary, yes or no. Is there pain or not? Is there fever or not? Yeah, it's something that is quite subtle, and it may not come out in the language that you use depending on what language they're comfortable in, right? So in Sarawak they may be comfortable. Their first tongue might be one of their local tongues, which may not be English or BM, right? So you have to think about all this when you design a study. Okay, next one. Read this. I give you 30 seconds to identify how you would improve this. What flaws would you be identifying here?
Probably the glaring one is record keeping, because you want to follow up for 10, 15 to 20 years. Not sure with regards to whether the record keeping is that for that long, whether we can get the data.
Okay, so that's one very obvious one. Can you go up to 20 years? Okay, but let's say we can, right? Because in UMMC, we know that even if it's not on the EMR, we know that we have our written records which are in storage. Yeah, okay. Anything else?
It's not so common peritoneal mesothelioma, isn't it?
Yep, okay, so rare disease. But again, rare disease doesn't mean that we cannot do rare disease, but it will be more challenging in collecting data. But that's not a flaw. Yeah, that's not a flaw. Okay, how long have we been doing HIPAC here?
Not sure.
Actually, I think it's about less than 10 years, yeah? Maybe 15 years, but it's definitely not 20 years. Okay, yeah? So it can be simple things like this. If you're not aware of the setting, you might design a study that is not feasible, okay? So you would not be able to follow up at 20 years for someone with HIPAC because we have not been doing HIPAC for 20 years, okay? So what else? I think you raised the issue of retrospective analysis and long-term and records, etc. Yeah, okay, good. Next one. What about this study might be affected by feasibility? You want to try? Yeah, go ahead.
Identifying common issue impacting the quality of life is quite difficult. That could be a perspective rather than a retrospective, isn't it?
Yeah, okay. So quality of life should be prospective, correct? Because if you ask someone to recall their quality of life 5 years ago, it's probably not going to be accurate. Yes, what else?
What type of bladder augmentation procedure? Maybe they can be a bit more specific there. Or
Okay.
is there just one?
Okay, so a good question. Yeah, so that is something that you would have to do your lit review on. How many types of procedures are there, right? Is one equivalent to another? Are you going to be comparing a very different procedure with very different outcomes, right? Very good. Yeah, so these are the things you need to be looking at. And in the first place, how often do we encounter this, right? Bladder augmentation for neurogenic bladder. We don't encounter it very often, although it is a known procedure, right? So then you will have to look at multi-center study. How many centers do you have to include to be able to get a good sample size, right? And not many centers will be able to do bladder augmentation for neurogenic bladder. So there are many layers when you design a study. And then when you think about all these things, then you have to identify which is it that is going to stop you from doing a study or affect how feasible the study is. Yeah? Okay, I think this is the last one. Last one. This is a very nice study, actually. Sounds so nice, right? So canggih.
I didn't understand the correlation between psychological assessment and dia punya genetic testing. That's maybe
Yeah, because it's
Okay.
genetic. Yeah, it's molecular testing. Yeah.
All right. So, okay. So if I heard someone say, I think Munira was saying you don't understand psychological assessment. Yeah. Okay. So genetic screening actually comes with psychological impact because you might screen and find a positive mutation in a person, in a patient who has not yet manifested any cancer. Okay, so they are in a limbo where they know they have the mutation, but they don't know when they're going to get the cancer. Okay, so that's why there are psychological assessments that are associated with genetic screening. All right, but I think Ida, I didn't hear you. Could you repeat what you said just now?
I think it's not feasible because of the cost. We don't usually check for P53 mutation, and it will incur a lot of costs.
Okay, all right. So Ida says it's not feasible because of the cost. Very good. But let's say you get a grant, which we know is also very unlikely, right? As a trainee, it's very difficult. And even if you do get a grant, the time lag in which you apply for the grant to the approval of the grant can be easily 6 months to 1 year, in which you have already wasted six months to a year of your 4-year program, right? 3.5 years if you consider that you have to pass out your thesis 6 months before, right? So again, this is a very nice study, but just not feasible for someone that has a defined timeline in which you need to start and finish your study, right? And even this effectiveness of early detection and treatment outcomes. How do you determine effectiveness in the time frame of 2.5 years to 3 years, which you have to do your thesis, right? So this makes it something that, although sounds very nice, is really not feasible at all for a trainee. Okay, so I think that is, yes, that was my last slide. Okay, and I'm going to stop sharing now because I wanted to make this a short and sweet presentation. Any questions from any of you? No questions?
Any questions in regards to your study designs or anything with clarification?
I think I've seen actually pretty much.
I have a
most-
question,
Yeah,
Prof. May I ask?
go ahead. Go ahead.
Is there like a real distinction between an audit and a retrospective cohort?
Yes. Okay. With qualification. So an audit is kind of a very kind of a single timeline, right? So you look at your cases, you look at incidence of morbidity. That's an audit, right? However, a retrospective cohort study, you would probably have a comparison group. And that makes it a research project rather than just an audit. Okay, so again, let's say you look at incidence of complications post-laparoscopic cholecystectomy in your center. That's an audit. You have the procedure, you have what you're looking for, which is rate of complications. But let's say how you can make it a retrospective cohort study and therefore make it a research project is a comparison, like I said just now, right? A comparison of rate of complications post-laparoscopic cholecystectomy between those done by specialists and those done by surgical trainees. Then that becomes more than an audit already. And they're both retrospective, but one becomes more than an audit. Do you understand?
Yeah, somewhat like you have two arms for, although it's retrospective, but for as long as somewhat like you have a two-arm situation, then it does qualify as a retrospective instead of just a simple audit.
Correct, that's right, yeah. Usually when there's a comparison group, that's right. I think for GS, you're not allowed to do audits, right? So there has to be a research element to it.
Yeah, they're not
And-
allowed to do audits, no. But of course, the method of collecting retrospective data could be like an audit method. Like you will collect data, like how you would collect audit data. It's maybe a method, but it's not supposed to be a study design. Yeah.
Okay, thank you.
Okay, anyone else? So I tried to keep it basically based on what I observed because I think that's more relevant and more practical for all of you who are having to pass our eagle eyes, yeah, when you come to us for your evaluations.
The problem with the question is, Prof, I think it's the co-founder factors that is not easy to compare. For me, lah.
Yeah, you're right, because often you may not be aware of it in the setting, right? It's not your home setting, not your home hospital, and you often don't have enough of the specialty expertise to be able to identify the confounder, because you're all still trainees. So in that case, actually, the supervisor is very important, and especially if you do it off-site, the supervisor in that setting has to be very aware of the confounders. Okay. Last question. Good. I'm in OT. I got to go back to the case. Anyone else?
If not, we
then
can end
yeah,
the session. Yeah.
yeah, we can end the
Yeah.
session.
Thank you so much,
Yeah,
Dr. Sorry, ask Tanya to moderate because I was in between another workshop and this. Yeah.
no problem. Yeah, no problem. and it was not a mistake when I said 5 to 5:30. I wanted it short and sweet so that we get to the
It has
points.
to be the 30 minutes. Yeah.
Yeah.
Thank you so much. I'm actually on my phone as well. So yeah, thank you so much. It was really good talk. I hope everyone learned some tips from this on how to improve their own methods. So thank you everyone for attending. Yeah.
Okay. All right. Bye, everyone. Thank you.
Thank you, Prof.
Thank you, Prof. Bye.
Thank you, Prof.
Thank you.
Thank you, Prof.